Hello, everybody. Welcome to this installment of the Practice Perfection Education Series. I'm Danny Bobrow, President of AIM Dental Marketing, and it's my pleasure to again have the privilege of introducing another visionary of oral systemic health. Tonight's presentation is entitled, Ride the Silver Tsunami Wave, Your Baby Boomer Delivery Guide, and it's presented by none other than Ms. Patti DiGangi. Patti is a vision-driven clinician, helping people make choices that ensure a profitable future. She holds a publishing license with the American Dental Association for current dental terminology and is an American Dental Association evidence-based champion. Patti is author of the Dental Codology series of easy-to-read books for busy people, helping prepare them for the upcoming electronic health record transition. As of January 2011, 10,000 people turned age 65 daily. This will continue every single day for the next 20 years. This unprecedented phenomenon is termed the silver tsunami. You already know that many oral symptoms can be a key indicator of a more serious health condition. This fact has particularly serious implications for baby boomers, many of whom cease their routine oral care visits. Reasons include a loss of dental benefits at retirement and a failure to recognize the value that maintaining oral health has for one's overall health, well-being, and longevity. Patti is here today to give us actionable steps to stem this tide. Before we get to her presentation, I want to thank and acknowledge the generosity of our underwriter for today's broadcast. Aseptico manufactures and distributes mobile dental delivery systems, as well as the WAND anesthesia delivery system. They help you to get to yes with your patients, making them the perfect practice perfection partner. Today's event is set to run for approximately 90 minutes. Feel free to submit any questions you have for Patti using the question form on your screen. We will do our best to get your answers, that is your questions, answered following her presentation. If we are unable to do that, Patti will be happy to respond personally following her presentation. As an attendee of this presentation, you are eligible to receive 1.5 hours of continuing education credit. Shortly following the webcast, you will be emailed instructions on how to receive your CE. Participants are cautioned about the dangers of incorporating techniques and procedures into their practices if the course has not provided them with adequate clinical experience to allow them to perform it competently. And now, it is my distinct pleasure to welcome to the Practice Perfection stage my friend and fellow AOSH founder, Patti DiGangi. Hello, Patti.
Hi, Danny. Thanks so much for that wonderful introduction. And thank you to everyone here listening for coming on tonight to talk about this really important subject. My first question, though, to you is, what's a senior? I know in my brain, the senior looks like that or that, you know, living fulfilled life, but kind of older. Here's the reality, though. This is what a senior really is now looking like. Now, those are two, you know that person. Yeah, those are, you know me. That's me. That's me. And let me tell you, I don't have a silver hair. What's this silver tsunami baloney? The reality of it, though, is that, as Danny said, 10,000 people a day turn 65. That started on January 1st, 2011, and it happened every day of 2011. Every day of 2012, every day of 2013, every day of 2014, every day of 2015 so far, and that pattern will continue till 2030. Now I go through it that way because I'm really trying to emphasize we have a very much of an aging population. So it's going to bring forward things that, well, a lot of things we don't know about. See, typical baby boomers, they're the generation that have kept their teeth for a lifetime. First generation that's really done that for a long time in this country. I'm a typical baby boomer. I've had full mouth reconstruction. As a matter of fact, just last week, one of my endo teeth, you know, I had lots of 8 root canals, but number 29 started bothering me. And what happened? It was this root fracture. So I had an extraction. I have a partial dry socket. I'm looking at an implant. But see, there's also my health. What's going on with my health, and how much is the health affecting the teeth, and how much of the teeth and my oral environment affecting my general health. Now, we know there's a connection, but how much of the connection, we don't know that well. Why? Because there's a body of research that we need for people living an entire lifetime and living into their 90s, 80s, 90s, and 100s with their teeth is just being formulated now. If you don't like getting older, well, think about it this way. This exact moment, you're the youngest you'll ever be. Wow, that kind of sounds cool. And it's also the oldest you've ever been. Kind of a funny game. Thank you, Eleanor Roosevelt, for that quote, but it's interesting thing how we see age, how we see the whole idea of aging has been declining. It's been negative. You're going to get more feeble. There's a lot of myths about aging. But even Barbie's aging. Oh, those circles. Yeah, poor Barbie. Guess she needs a little bit of better, under makeup there to help cover up those circles under her eyes. Maybe a little Botox, yeah. Because, see, we baby boomers will spend all kinds of money to try and stay young. The question becomes, though, how many people die each day from oral disease? Now, we don't have the numbers on that. Why don't we have numbers on that? Because the connections and the records and the data is just not there. But I'm sure each of you listening probably knows that it does happen every day. It does happen every day, and there's ways that we can stem the tide. And that's what we're going to talk about in our time here together tonight. We're not going to talk about the lifespan. We're going to talk about how we can expand the health span. That living a long time, but living a quality life all the way through to the last moment. So again, we're going to talk a little bit more about the lifespan, health span. We're going to talk about some of the most recent oral systemic information, the connections we have to periocaries, oral cancer, all of the oral diseases we're all familiar with. Here's something that's a question that has never really been that important to us in dentistry before, but it's going to become more and more with our baby boomers aging. Will Medicare cover it? Your automatic answer might be no, but that is not necessarily the right answer. And I'm going to give you 5 simple action steps to kind of make it all come together and work together. As Dan said, I am thrilled and honored that I have an educational grant from Receptaco, and with their wonderful family of products, I know I had the wand used on me for my anesthesia just last week. Wow, it was great because, dentistry, I don't really like it that much, but on my own mouth. But boy, did it make me comfortable. It was really, really a comfortable situation. So again, thank you to Receptaco for sponsoring this program. Now, that's my husband and I. And it was really funny. Okay, we've been married 30 years, and we actually took me 30 years to get him to go zip lining. That's what that crazy outfit is. But he asked me, out of the blue, not too long ago, will we end up with dentures? I go, what? He said, we end up with dentures. So I'm like, why would you ask me that? Now, I told you about my baby boomer experience, that I have the whole mouth full of dentistry and all that stuff. Not him. Of course, he has that silver hair and silver stuff going. But he's had 2 fillings in his entire life and 1 crown. That's it. I go, why would you ask me if we're going to end up with dentures? He said, because I keep seeing all these commercials on TV about, one-day implants and all that stuff. Even people with the greatest knowledge, a lot of knowledge, advertising doesn't make a difference. And that's why I wrote that article that was in RDH magazine just last year, in August of last year, about, health span versus lifespan. How do we create and how do we contribute to creating a world where health is something that we can have all our lives? Now, this is a great book. I recommend it. It's a great read about where we're at as a generation, but it's not just about the baby boomers. It's really about all the different cohorts that we have out there. And one of the things, Paul Taylor himself is, he's turned 66 this year. He said, the baby boomers are just realizing they're getting older, and they aren't liking it. Because this is the, think young generation. It's the generation that's never going to grow old, except we are. So which generation are you from? Now, with the number of people on this call, it's very possible that we have somebody from each of those cohorts. Including the greatest generation? Yes, absolutely. I have people in my courses that definitely will fall into that. Why? Because we're living longer, we're practicing longer, and we're interested in still stretching our minds. Now, that's the generation that certainly might need some oral care assistance, that may end up in nursing homes, but not as many as you think. Just answer this question to yourself. What percentage of the U.S. population do you think ends up in nursing care? I've gotten answers anywhere from 20%, 30%, as high as 75%. But here's the real answer. Only 5% end up in nursing care. Now, 5% of 330 million is a lot of people, but it still isn't everybody. See, 95% of people are either in their homes by themselves, or they're in the homes of a loved one or a caregiver. So that greatest generation, actually, plus the 85 crowd, they're the ones that's the fastest growing group. Now there's the boomers that I talked about, and we talked about as part of, the main thrust of this course today. 76 million, we kept our teeth for a lifetime, but like me, many have invested a lot of money in their oral health. Thing is that when they retire, many of them retire out of their dental benefits, and their choices become very different because of that. Then there's the Generation X people. Now that's my two older kids or children are in that cohort. About 43 million of them. And again, what's the breakup on the years they were born and all that? That's open to interpretation. This Gen X generation, well, they're the ones that are in their 30s and 40s now, and they really got squeezed by the economy, by when they bought their houses. For them, well, first of all, they look at it, the boomers don't want to retire. So they don't think they can't ever get forward, and the retirement actually just seems impossible to them. Many of them question whether or not the prevention that they were taught and their parents took them for is really worth it, because it's that cohort, it's just the millennials and Gen Xers, they're not coming to the dental office the same way they did in the past. Because that 82 million millennials, now that's what's interesting. I say the boomers are the biggest, but the numbers actually show the millennials, there's 82 million of them. They don't have, one of them don't have dental benefits at all. They change jobs, they also very frequently, and they also have that invincibility of youth. We don't need it. We don't need it, we don't value it. Who besides me finds this really irritating? And nurse, that's fine. No Wi-Fi, talk to each other, call your mom. You know what I say to that actually? Baloney. Almost all of us, that's our world anymore. Our cell phones. And yeah, we're looking down on them. It just seems to irritate us when they're millennials. It's a great communication venue. It's a way, there's probably a bunch of people on this call that are listening to this on your cell phone. I am using my cell phone to broadcast this. It's the world we live in. You don't like it? Get over it. But we have another divide, and that's the divide between the digital immigrants and the digital natives. Now, this is not completely true that anybody that's a boomer and has gray hair isn't. Well, they are digital immigrants. What do those terms mean? A digital immigrant is somebody that was born long before the era of computers. Well, that makes a lot of us. As a matter of fact, a digital native is usually someone that's born after 1989 or 90. Now, it's not a good or bad. It's a matter of the digital natives, they don't have to read the instructions. They just know. If you ever have, if you're a boomer like me, you've got, grandchildren, my granddaughter showed me a function on my cell phone the last time she had it. Really? She was 3.5 at the time. Yeah, that's a digital native. Again, not good and bad, but this is what's really influencing our present and will even be influenced this greater in the future, particularly in our practices, because we are truly a profession in transition. What may have been successful and worked extremely well in the past is not going to be the same, and it's not even working that well right now. What's interesting is ADA, American Dental Association, has this group called the Health Policy Institute. If you're not familiar with it, go onto the ADA website and look up the Health Policy Institute. What they've done is they've hired some economists to actually look at trends. And the trends that they're discovering are very, very interesting. One of them is that expenditures on dentistry began to slow in 2002, fully 13 years ago. Well, when the economy crashed in 2008, you know, everybody crashed. But here's what's really interesting is look at the trend after that. Wow. Healthcare expenditures have come back on some ends, but not dentistry. We're still down. And here's the reality is we're still flat. That was through 2008 to 2011, but just look at the last couple of years. Spending is flat in dentistry. Now, there's lots of different interpretations to that we can make, and people go, oh, it's insurance, it's this, it's that. You know what? Those are the easy answers. Sometimes we need to dig a little deeper as to why. I mentioned one already. Where the spending and where the investment is really flat is in the people in those millennial and Gen Xers. They're not valuing and they're not spending, they're not investing their money in what we consider their usual oral health, in prevention. Why is that? I'm sure there's lots of reasons. But here's another one. This is another part of the Health Policy Institute. There is an opportunity. We have a big opportunity for screening for chronic disease in the dental office, because we know that there's a lot of productivity that's lost, and the estimate there is $153 billion that's lost every year for the management of chronic disease. And we have an opportunity in dentistry to make a difference. Look at the numbers. Look at the numbers. Screening for diseases in the dental office could reduce healthcare costs by $102.6 million a year, or $32.72 a person screens. Now, is that much? Well, yeah. I'd take $102.6 million. How about one of you? Yeah, lots of opportunity here. But it's not going to happen if we continue to do what we've always done. To continue to do what we've always done and think we're going to get a different result is called the recipe for, what's that word? Oh, yeah, insanity. Insanity. So we got to think differently. And one of the ways we think differently is by using different language. Now, this isn't about being politically correct. It's about using language that's more accurate to current circumstances or more concise to give us more specific meaning. A lot of us have learned how to do that with going on Twitter. 140 characters. Got to be concise when you're using that. Well, one of the terms that we can really change our thinking is by changing the word elderly to elder. Think about that. Just removing those two letters. Now, we think elderly. If you close your eyes, you're seeing someone bent over on a cane, infirmed. But when you think of the word elder, you think of respect, trust, wisdom. What a wonderful way to look at it. And as this lady here says, the great thing about getting old is you don't lose all the other ages you've been before. The learning that's possible with that could have happened at all those ages. See, learning should never stop at any point in our lives. Unfortunately, we really don't have a healthcare system. We have a sick care system. What do I mean by that? Well, we're focused on controlling systemic fires like heart disease, diabetes, arthritis, dementia. In dentistry, we're looking for periodontal disease, oral cancer, and caries that have gone into cavities. Oh, there's a term that we can work on. The idea that the word cavities and caries are interchangeable is incorrect. Caries is the infectious process. A cavity is the outcome. Language makes a difference in how we think. We don't spend a lot of time preventing much of anything in reality. Now, I am sure that there's hygienists on that call, as I am on this call, that are going, wait a second, we prevent. Well, let's first talk about our detection modalities. When you're scratching around with a slur, what are you looking for? A hole. When you're probing, what are you looking for? Pockets and bleeding. When you're palpating, what are you looking for? Lumps and bumps. What are you using to measure health? Have you ever had any patients that had too much health? We don't know because we don't measure health. We measure disease. Lifespan's how long we live. Health span's how long we live in the best possible health. I love that graphic. Sick care, there's a whole, who has a medicine cabinet like that? Or somewhere in your house. Health care nutrition, healthy food. Oh, that's such a pain. But that's really a lot of the answers right there in that picture. So anybody who's ever heard me present before, they know Patti's famous paradigm shift discussion. See, that word paradigm is an interesting word. It's used a lot. When I first heard it 20 years ago, I heard paradigm, right? I thought it was two dimes, like, 2 coins. Okay, then I saw it spelled out, and I thought it was paradigm. And then I heard people use it all the time lately, and it's like the paradigm changing product, or no, it's not really what a paradigm is. A paradigm is a system. Well, actually, it's the philosophy underneath a system. It's a bit like culture. It's invisible until you talk to somebody from a different culture. All of us here in healthcare in the U.S., we are, our education, our training, our science, all comes from a particular paradigm or a particular belief system. It gives us the rules of the road. It gives us the boundaries of our science. And it is disease-based. If it ain't broke, don't fix it. And that includes the practice of dental hygiene. It ain't broke, don't fix it. Really, come on, prevention. I'm going to challenge you on that. The thing about paradigm that's really interesting is it's really how the brain, actually, it's how the brain works and the eyes work. Even as you're listening, put your hand in front of your face. I'm doing it. And here's the thing about the brain and the eyes. Within a very, very short period of time, your brain and your eyes will adjust till you no longer see those fingers in front of your face. That's how a paradigm works. A paradigm is invisible, but it gives us the boundaries of our thinking. Now, even though you don't see those fingers anymore because your brain and your eyes exist, get rid of it, the view of them, they still exist, don't they? And blocks part of your vision. That's what a paradigm can do. It can block part of your vision, block the possibility. Now that health continuum I have up there is, do anyone want time to find a visual that really showed what I was talking about with this? I will submit to you that we spend the majority of our time in dentistry and most of healthcare here looking for moderate to severe disease. Again, pockets and bleeding, holes in a tooth, lumps and bumps. But in addition, there are 3 levels actually of prevention that I want to redefine for you. I'm going to have you think a different way. Now, I've adapted this from a textbook I found a couple years ago called Oral Pre-Cancer. I love the name of that book. The editor in the very beginning introduction, he said, one of the problems that we have when it comes to oral cancer is that we're looking for cancer. We need to start looking for pre-cancer. Or as my friend Debbie Z says, oral abnormalities. Oral abnormalities. Well, in the textbook, they've redefined the 3 levels of prevention this way. And I've adapted them because it makes sense all the way around. Primary prevention is when we avoid the development of the disease by eliminating the principal risk factors. Okay, fine. What does that mean? Well, let me put it into a realm that you might be able to relate to a little easier. Sometimes when it comes to dentistry and risk factors, we're a little fuzzy about that. But I know that I carry risk factors for colon cancer because my father and 5 of his siblings have had colon cancer. As a matter of fact, I have a very high risk, don't I? But my father did genetic testing, and now we know we carry the genetic link for colon cancer. As a baby boomer, I've had my baseline colonoscopies, according to the schedule that's recommended for most everyone. But I have a 25-year-old son. Now that we know we carry this genetic link, when should he be screened? See, primary prevention would dictate that he is screened earlier. I'm sure you all can agree with that. That's what primary prevention is. Let's go back to the other side and let's look at where that fits. In our usual continuum, if you see, it's here before we actually see any signs and symptoms with our usual detection modalities. That's where primary prevention actually occurs. Then we have secondary prevention. That's the detection of early disease, early breakdown, a stage where the intervention might lead to an outright cure or reduce the amount of damage. When I was in dental hygiene school, I didn't learn about healing teeth, but we can heal teeth. Well, here's what I actually believe. I believe that we can heal teeth and meet the 2020 goal of the World Federation of Dentistry to have a caries-free world. Did you hear me? Yeah, 2020, we're going to have a caries-free world. Do you believe it?
Amen.
How about, I will. Yeah. How about, do you believe that we can cure periodontal disease? Do you believe that we could have a world with no oral cancer? See, it's the internalization of those beliefs that really creates this world of prevention. And then in the tertiary prevention world, there still is some that we're not going to have dentistry to do. I mean, you know, we have high goals, but it's to reduce the recurrence. Think about it, how often we not only see recurrence of disease, we expect recurrence of disease. And then to minimize the related complications. That's the new prevention, 3 levels of prevention. Now, and look at this, what we know about the aging, because we've got some myths that we've brought into there. The Baltimore Longitudinal Study on Aging is a study that was funded by the National Institutes of Health. When I was doing research to try and find, you know, where's our research, body of research on aging and oral health, guess what, we don't have very much, but this is a great portal. It's a great place to go. It's been going on for a long time. Now, one of the things that's interesting about the research they do there, they, in the beginning years, back in the early 70s when this research started, they were using people in nursing homes as to research aging. The reason is that when you're doing research, following people over time is really important. And people in nursing homes you could follow. Now, they were there for the follow-up studies and all. Until one of the scientists came along and said, wait a second, we're skewing our research. And of course, these are the top scientists and all that. And they're going, no, what are you talking about? We're the best. And this one individual really pushed, he goes, no, we are skewing our research because, yes, following people over time is important, but we're making these generalizations about aging based on people that are already infirmed enough to be in a nursing home. Duh. Like a lot of things in life, when we really get it, have that epiphany of, wow, yeah, that doesn't make sense. So what they did is they decided to do research on people that are healthy to distinguish what is normal with aging and what is caused by disease. And as you can see, that's the 3 major conclusions that you're looking at there. Normal aging can be distinguished from disease. Change is normal, disease is not inevitable. And there's no chronological table for human aging. It doesn't mean just because you get to a certain age, your knees should hurt. Things like that. Here's some myths in dentistry that we have about aging. Aging is a risk factor for oral cancer. I disagree. If you really dig down into the research, the reality of it is most oral cancers are not found until they're stage 3 or stage 4. That means there's been a significant delay in diagnosis. So aging isn't the risk. What that shows is that the problem has been late diagnosis. Root decay always happens in older patients. Well, common, yes. Doesn't mean it has to go that way. Vital signs are a choice. You know, in dentistry, we really don't need to do that unless we have time. A huge myth is just brushing and flossing twice a day is needed to prevent oral disease. Whew. I didn't want to get into that one tonight. And dry mouth is standard with aging. Again, it's common. It doesn't mean it's standard. Now, I'm going to take a little bit closer look at 2 of these. One is restorative dentistry restores oral health. This is where we have another language problem. See, restorative dentistry has been the traditional thing that we call the crowns and the fillings and all of that stuff that we do. But see, that really isn't restorative dentistry. That's prosthetic dentistry. And there's a difference between prosthetic repair and restoration of health. Restorative dentistry, as we've known it, or prosthetic care, doesn't restore oral health. Why? Because it doesn't stop the causative factors. It repairs the damage after the horse is out of the barn. And the other one, changes in the 5 sentences don't make any difference. Well, that one is something that we see all the time, but we may not realize it. Age-related sensory loss, it does happen. Now, how much it happens, how much is on the normal scale, the sensory declination, there's some questions on it. They're still doing a lot of research on that. For one thing, like it seems like the highest loss of the senses is in the eyes. The second is in the ears, but that one's coming under question because of headphones and rock music. But one that we see all the time in dentistry is, you know, patients maybe we've been seeing for a really long time, and they've had really pretty good health, oral health. You know, I mean, you know, it could always be better or whatever. But all of a sudden they're coming in and they got the firm mouth. They got something that looks like that. What that can be is from the loss of the sense of touch. Vision too, but touch. See, the sense of touch is not something that's just limited to your fingers, but it's your tongue too. Because I know as a dental hygienist, I thought, there's a lot of my friends have said they have too, it's like, can't they feel this? The answer might be not in the same way they did before. That's the reality of it. Now we know that there's a big inflammatory effect from that. That's why our first step is change your language, use different words differently. The second is evaluate for inflammation. These are the common connections, or the most common systemic diseases seen in functionally independent older adults. And all of them involve inflammation. Is periodontal disease connected to them all? There's a connection. We'll talk more about that in a moment. But which one of these commonly diseases doesn't end up on the death certificate as a cause of death? Well, that's where this really comes in, this scale. It's all about we don't find things until they're moderate to severe. Something called metabolic syndrome. Love that sign. Yes, it's the widening of our society, widening of many people, and it does not have an age basis. As a matter of fact, a lot of the age-based thinking that we have thought before doesn't make sense with science as we know it now. What is metabolic syndrome? Well, it's not something you usually find on a health history. It's a combination of factors, and that's why it's called a syndrome. And it usually is that, as you can see there, the visceral obesity, although it's not, there's some people that say it's a certain size waist, but that is not universally agreed upon. But it is insulin resistant, low HDL cholesterol, hypertension, high triglycerides. But again, it doesn't usually show up on a health history. 34% of Americans have some level of this, and they're twice the risk for coronary heart disease. As you can see, there are cirrhosis, type 2 diabetes, and stroke. Twice the risk, twice to 5 times the risk, depending on the factors. That's why you can put the clues together with your health histories, because again, they're not usually on there. Now, if someone has 3 of those 5 factors, go back to the factors, 3 of 5 of these, that means that they could have the diagnosis of metabolic syndrome. Or what they have is the risk, an increased risk for all of these diseases. Where will we see it? Well, we may or may not see it marked on the health history, but we may see it with the medications they're taking. If they're taking medications for hypertension and cholesterol and, that means that they have the diagnosis of metabolic syndrome, and that means they're at high risk. Now, we think, and the patients themselves think, that the medications are going to reduce their risk. They do a little bit, but they don't completely because they don't get rid of the causative factors. Another thing, too, when we're talking about this health history, and this is whether it's a paper form or an electronic form, 20% of the American public are functionally illiterate, with another 35% only reading from a 6th to 10th grade level. So we give them these histories like this to fill out. How many times are they going to check, because you don't even understand them? That's where we put the clues together. Then there's the vital signs. Now, isn't that profound? Vital signs are vital. Yeah, we're all taught them in our education, yet they're often one of those things that go away almost immediately when we start in practice. But vital signs are vital for establishing medical dental necessity. Now, that's not a term that we're well versed in dentistry, but it's a term, especially as we move farther into electronic records and when we talk about insurance and Medicare, that is something that's really important. Another term that I have there in parentheses is meaningful use. Medicine is a bit farther ahead in electronic health records, and they know they're actually in stage 3 meaningful use. That means that health records, medical health records, have to have vital signs, they have to show smoking status, and a number of other things in order for the practitioners to be paid. Now, smoking status, how easy is that for us to document? Thing is that what this little chart here that I have isn't accurate for. If it says former smoker, we need to know when they stopped. See, when it comes to oral cancer, the risk stays as high as if they're still using for 10 years after they stop. And it really shouldn't even be smoking status, it should be tobacco use. But these are a couple of things that actually can give you a ladder up on where we're going with electronic health records. Now, when I talk about electronic health records, I'm not talking about our paperless practices. I'm talking about the step beyond that. When dentistry talks to medicine and pharmacy and we all connect. It's not going to be Big Brother has all of our, records in one central database. It's going to be more like our cell phones. There's a system that they connect. Speaking of connections, you notice on most of my slides I don't have any references. I do that on purpose because just because somebody has something little on the bottom of the side doesn't necessarily make it more scientific. But I leave it on here because of the homage I'm paying to Dr. Jenko, one of the most amazing researchers out at University of Buffalo. He talked about this based on the work that he did with the Pima Indians. See, it's that connection between obesity, diabetes, and periodontal disease. And what his work showed over and over is that if they don't have their diabetes under control, we're not going to have the periodontal disease under control. But obesity is part of that triangular. It's not just bidirectional, it's triangular. So what does that mean for us practitioners? Does that mean we need to do some dietary counseling? Oh, that might be exactly what it means. Because of the risk for heart disease. That is the #1 killer of women and the #1 killer of men. Now, we've known it's the #1 killer of men, and that's gotten lots of attention. But the #1 cause of women, we forget that part. In 2012, the American Heart Association, with the support of the American Dental Association, as well as the American Academy of Periodontology, came out with a position paper that said there's no evidence that gum disease causes cardiovascular disease. What? What? What's that crazy statement all about? Let's look at it a little closer. What they said is there's no evidence that gum disease causes cardiovascular disease. That's the key word. Causation. As you can see, there's a difference between association and causality. Association means they share characteristics, possibly risk factors. One doesn't cause the other. See, in order to have causality scientifically proven, we have to have irrefutable proof that one entity is the consequence of the other. And what's interesting is there's some research, actually some research that was done at Forsyth, that asked the question, do oral bacteria play a part in the pathogenesis of obesity? What? See, this causality, which way does it go? The connection. Those questions are being researched and continue to be researched every day. Do we know that there's absolutely an association? Yes, we do. Do we have the science yet for causality? Not completely yet. That's why we have to be also very careful with our language on that. This is Dr. Mulberry Mers, who was the head of the Women's Heart Study. Now, when the results of that came out a couple of years ago, caused a big flurry because the media got a hold of it, and the big headlines is that your hormones caused you to have a higher risk for heart attack. So women across the country wholesale got off their hormones. Well, what's interesting is since then, many women have gone back on them. Why? They didn't like the side effects. Now, there's all kinds of things we could talk about with hormones, and I'm not going to talk about that. But what I want to talk about is what the really important part of that study showed that kind of was missed. I heard her speak through a TED Talk. If you've never heard of TED Talks, write that down. TED Talks are amazing. They are presentations that are no longer than 16 to 23 minutes, but some of the greatest minds, and you talk about concise language, listen to a TED Talk. There's all kinds of them out there. And that's the first time I heard Dr. Mers speak on this. And what she said is that what the research showed in the Women's Heart Study is that since 1984, more women die than men of heart disease. And if you look at the blue trend line, for men, the trend is going down, down, down. For women, the trend is going up, up, up. And because of the way, what the research showed is that it's not a change in risk factors. There was something else going on that was affecting women. And what their conclusion was is that the diagnostic and therapeutic strategies for heart disease were developed in men, by men, for men for the past 50 years, and they worked pretty well in men, but not so much for women. That's quoting Dr. Mers. What does that really mean? It's about the way research was done. The paradigm of our research was to, in general, not factor the difference between men and women. See, if there was research and women came out high and men came out low, everybody comes out average. And that's where we get what can be confusing or completely inaccurate information. Here's a question that's going to stretch your brain. Is there a gender bias in diagnosing and treating periodontal disease? Are men or women more susceptible to periodontal breakdown? I don't know those answers because I don't know that those questions have been asked. See, part of what predicates how we find out what we find in research is what question we ask. I mentioned that one about just asking the question about is our periodontal pathogens involved with the pathogenesis of obesity? Wow. By the way, the preliminary research showed that there was enough information in their preliminary research to do further research on that. But what's the question that's being asked? And here's a real question. We're looking at this probe. We're looking at all these pictures, this continuum of breakdown. Here's the question. Is it perio? Or is it diabetes? Or is it something else? Where does periodontal disease start? Start in a 4-millimeter pocket? Start in a 6-millimeter pocket? That question alone is based on a disease paradigm. See, periodontal disease starts in health. Yeah, in health. That's why, this tradition of only writing down if something's over 3 millimeters, that's because we're so disease-oriented. I usually probe at 1s and 2s. If I probe at 2s and 3s, does it mean I have pathology? Well, first of all, I certainly didn't give you enough information if I only gave you pocket depths. But if I change from 1s and 2s to 2s and 3s, do I have pathology? Well, not by our traditional way of looking at it, but I certainly have changed that you need to look at differently. It's time for different testing and different thinking all the way around. The medical and dental world really needs to come together. The way on the medical side is diagnostic tests happen prior to treatment. You have the basic data gathering, the risk assessment, the diagnostic tests are ordered, the diagnosis is made, and then the appropriate treatment planning. I will submit to you that dentistry skips the right side of this picture most of the time. We just do some basic data gathering and then we do treatment. The diagnostic tests can be so much more robust. Genetic testing, there's a genetic test out there that tells us if you have a polymorphism, that you have a higher level of inflammation. You think that's probably something important to know, kind of like it's important for my family to know that I carry the gene for colon cancer? And then what's the actual diagnosis? As many of you know, and as Danny introduced, I wrote some books on insurance and insurance coding, and almost every time I get a question, I ask them what the diagnosis is. And they'll tell me Stanley Replanning, or they'll tell me a crown, or something. It's not a diagnosis, that's a treatment. And then it's like, what is the measurability of the treatment? Did the treatment work? It's really important because in the future, we're going to get paid based on these things. Not based on just doing stuff, but based on, is the treatment the right treatment, and did it work? We can make a difference. We really can make a difference by changing our thinking in this way. So we are going to change our language. We're going to measure for inflammation, and then we're going to change our care based on oral systemic connections. Now, we've been lots of courses out there for a lot of years, a lot of articles, a lot of this, a lot of that, oral systemic, but here's the question, what are you really doing differently because of that information? And the answer for many of us is not very much. Dental hygiene is still usually propy. You know, is it really changing things that much? Look at this picture. What kind of prevention can we do here? Okay, come on, Patti, the horse is out of the barn. What do you mean prevention? Well, say again, it really doesn't matter the person's age. But should we go in and just start, you know, doing what? All kinds of restorative, what has been traditionally restorative prosthetic dentistry? I don't think so. Because that will not solve the problems that created this in the first place. There's something called atraumatic restorative treatment that's done. People go to the mission fields, or they go to, you know, other countries, and they see such tremendous amounts of breakdown. They do lots of extraction, and they do this art. That's why it was officially endorsed by the World Health Organization 21 years ago. And basically what it is you got a situation like this. We know that we've got a really advanced situation. So you take a spoon excavator, you take out the soft stuff. Looks like they're using a rubber dam on this one. I don't think we're going to do that on the other one. But you take out the soft stuff, and then you seal it with a glass ionomer. Did you hear me say we're sealing over this? Yes, that's exactly what I said. Why? Because what you want to do is you're sealing off that area. It acts as a physical barrier against the biofilm pH destruction so that you can help the person actually restore their health. And then eventually restore their teeth if they want to, they can, or they can afford to. The thing is that with this glass ionomer product, you can put more fluoride on it and it recharges it. It goes through the material. You see a couple of the GC products there are ones that are really good for that. Actually, some of us may have been using or Fuji Triage, glass ionomer sealant, because, you know, let's talk about a young person where they've got, you know, they've already got a big mess, they're high risk, they've got that tooth erupting, you know, 6-year-old molar erupting, the operculum still partially covering it. One of the things about this glass ionomer is you not only can have a wet field, you need a wet field to put it in. Wet field? Yeah, just think about that. Cool. But that's a different type of prevention, isn't it? That's a redefinition. What's interesting about that art, it's also called interim therapeutic restoration by the American Academy of Pediatric Dentistry. And with multiple people logging as of 2014, we even have a code for it. Interim therapeutic restoration of primary dentition, as you can see. When I talk about coding, you can see my license down there. I have to have that on there. That's the first book that I wrote on coding and more. But what's interesting is, what about the adults? We have to talk about the baby boomers here. We can't use the primary dentition now. This is a code that used to be the temporary filling code. But if you look at how it's been redefined, it really fits this procedure. Direct placement of restorative material to protect tooth and/or tissue form may be used to relieve pain, promote healing, prevent further deterioration. Wow, it sounds exactly what it's about. But think about that code as a code. A protective restoration. That, to me, is that earlier level prevention type code, isn't it? Yeah, it sure is. Do we need have them come in the office? No, we can have access to care. We can take this to where the people are. And again, that's where the wonderful receptacle equipment comes in. Whether it's the unit, and look at that, isn't that awesome? It's so small, it can be carried, you can go in and go into all different places. Of course, you know, with hygiene, there's practice acts that regulate the fact that we can't do that. But there's 37 states in which there are some levels of some kind of expanded practice. It's happening more and more. I believe it's going to happen more and more in the future for there to be mid-level providers because we need it. Because we need it. So we've done 3 steps. Change our language, inflammation, change what we're doing based on what we know about inflammation and inflammatory effect. Next is to recognize and do something about any kind of abuse. It's estimated that more than 1 million elders are victims of abuse every year. All types of abuse. My father-in-law, oh, we got to the point with him, he was so open to scams. And then he was lonely, so if anybody called him on the phone, he'd buy anything. That's a type of abuse. You know, there's a physical abuse, all kinds of abuse, but is this abuse? That's elder abuse, in my opinion. Now, I'll tell you the story of Ida. Ida was 102. She was a weightlifter, as you can see her there in the exercise room. She lived in Winter Park, Florida. And she was so known for being a weightlifter all her life. Somebody from Belgium came with a team of reporters from the country of Belgium and did a video on her. And she was news in Belgium. Well, I got kind of feisty, you know. She's like, hey, I'm cool. You know, I had a video. I was on the news. And she stopped using her walker. Now, she fell, and she broke her leg. And breaking her leg was serious at any age. But Ida was in really pretty good shape. But Ida was then relegated to be in bed for healing. And I wasn't moving very much. And Ida ended up getting pneumonia. And Ida was treated for pneumonia. And Ida got pneumonia in both lungs. And she had more treatment, more antibiotics. And more antibiotics. During that period of time, no one was caring for Ida's oral care because a lot of times people that work in nursing homes don't want to do the oral care. Ugh, to them. They look at this kind of thing and, ugh, I don't want to deal with that. Ida died. Now, did Ida die of her broken leg? Did Ida die of pneumonia? Or did Ida die from her dirty mouth? Or the very possible yeast fungal overgrowth that no one was disrupting that biofilm in her mouth? Dying from dirty teeth. That is the name of a book written by my dear friend, Angie Stone. She'll be presenting with Danny next month on this. I was privileged to be a first reader of this amazing book. And as you can see from the title, Why Lack of Proper Oral Care is Killing Nursing Home Residents and How to Prevent It. She's this lady with a mission, and she needs all of our help. But all of our help in our thinking, as well as in other ways. So come back, definitely come back and tell all your friends about the program with Angie next time. So we have this aging population. We have these baby boomers getting older and older. There's part of me that doesn't want to say this, but I did graduate from hygiene school in 1973. I'm 62. I now have several friends that are on Medicare. And a couple of them, they're really thrilled to be there because their insurance is getting less and less from their jobs, or they had to retire early. So the question becomes for a lot of people, will Medicare cover it? And the automatic answer from most dental professionals is no. Dentistry is not covered. Well, that may or may not be true. The problem is any time, particularly clinicians, start talking about what's covered, we're going down a path. We're going down a path that is often your information is based on what? Right now, There is a period of time, we're in a very, very dramatic period of time. ADA News says this way, dentists must choose to opt in or opt out of Medicare. For an awful lot of practitioners, they don't have any idea what that means. They think Medicare doesn't have anything to do with practice, Medicare doesn't cover anything, we don't accept Medicare, so therefore I can just ignore this. That is definitely at their peril, because the game in healthcare is changing. I'm a member of the National Association of Dental Plans, and at their last meeting in Florida last September, they were talking a great deal about the Affordable Care Act, about Medicare, and a lot of the changes that are happening. And no matter what anybody believes, no matter what anybody's politics is, the arena of healthcare is changing. Not paying attention to Medicare is at your peril, because what this National Association of Plans is doing is, as Medicare goes, is the way all insurance, private insurance, is watching and going to. So it's a very important thing to be aware of. Something that happened last year that I think is really, really exciting, yet some people have spun negatively, is that the Centers for Medicare and Medicaid Services redefined what is the definition of a physician/practitioner. And again, you see I have it quoted there. For the purposes of this provision, the term physician is limited to doctors of medicine, doctors of osteopathy, doctors of dental surgery, of dental medicine. Hooray! This whole oral systemic thing, look at that, we're smack dab in the middle of it. Yet there's some people that are protesting it. Why? Because it also put us smack dab in the middle of this whole Medicare thing. Although we were there anyway. See, with electronic health records, one of the things that practitioners had to do is get a national provider identifier, MPI number. If someone has an MPI number, which basically you have to have an MPI number in the world that we practice in, you are already part of the Medicare system. And there is a pivotal time that's going on right now that every dental practitioner has to decide, and practice has to decide by the 1st of June to either opt into Medicare, opt out of Medicare, or do nothing. Opt-in comes with a couple of choices, but I'm going to tell you every one of these choices has a cost. A cost in whether you do, whether you don't, but I think the biggest cost is doing nothing. Because doing nothing, well, that's easier, we'll just wait till they catch us. No, it's not about that. It's about something as simple as writing a prescription, making a referral, or having coverage for other medical devices. The dentists that don't take action, the first time they might see an impact is when they've written a prescription for one of their patients that's under Medicare. And by the way, Medicare is not just for older people. Medicare is yes for everybody over 65, but there are a lot of other people that are also under Medicare because of a disability. So the age is not the only thing we need to think about with this. But what happens is the dentist writes a prescription. The person takes it to the pharmacy, and it would normally covered under their Medicare. If the dentist has not made a choice, again, opt in or opt out, and the different ways you can opt in, then then the patient will not be reimbursed for or get their prescription paid for. So they might get that, they need a Z-Pack because they have an infection, and it's going to cost them, $350 versus a $5 copay. Yeah, that's dramatic. That's dramatic. And whatever decision is made by the practice by June 1st, it's going to lock them in or lock them out for the next 2 years. You can't change your mind in between and decide in September this year, oh, we changed our mind. The decision has to be made by June 1st. And there's a lot of paperwork. The greatest amount of paperwork comes in the opt-out. I'm just as far as I'm going to go with it for this particular thing, but it's what part of what's influencing our world now, particularly with our baby boomers. Because when my husband retires and when we reach 65, yeah, we're going to have Medicare. What's going to happen then for me? What am I going to do? That's the question that everybody's asking. That's why these questions that before may not have made a difference in practice will make a difference in practice to us in the very near future. That's why the next version of Dermcodology, an ebook, will be coming out by March 1st. That it talks to this. What you need to know about Medicare. It's an ebook. You can pre-order it. There's another ebook, another book, printed book that's coming out in the Dermcodology series on April 1st, and that's What's the Evidence and How Do We Say It? And that talks about how evidence-based decision-making will influence best practices, which will also be part of the payment system in the future. Now, a lot of clinicians on here going, I don't like this stuff. Yeah, well, whether you like it or not, it's the reality of where we are at this point. So, 4 steps so far. Think about our language. Evaluate for inflammation. Do something different with oral systemic. Notice and do something about any type of abuse. You know, part of the act, and we know about child abuse and our duty to report that. We have just as high of a duty no matter what the age. The action step 5 is one it's about your patients, but it's just as much about you, and it's about brain fitness. Now, you've probably seen lots of things online about brain fitness, and on TV there's commercials, luminosity, and all those things that can talk about brain fitness, because for most of us, you know, we certainly don't want our body to break down, but we sure don't want our brains to break down, do we? There it is. That's what I was talking before about the digital natives. Yeah, Grandma, double click on the Internet Explorer icon. Yeah, forgetful.
That's great.
Yeah. Now, the thing is, here's the sad news for us. On average, forgetfulness starts at age 35. Oh, my. Now, I swear I did this just a little while ago. I started to walk upstairs and go, why am I going upstairs? You know, what I do with the keys, I read a thing on Facebook, which is very authoritative about, you know, how to keep your brain fit. One of the ways you keep your brain fit is to spend time with your grandchildren. Well, not too much, though, because if you spend more than 5 days with your grandchildren, then it starts going the opposite way. Okay, no science behind that, just a little bit of a joke. But how many of you play Sudoku or crossword puzzle to keep your brain fit? Like, oh, yeah, I saw that stuff. I like doing that stuff. Well, the research isn't. It does not increase your brain fitness. What the research is showing, people that pay lots of Sudoku and lots of crossword puzzles get really good at Sudoku and crossword puzzles, okay? See, we can really just go from one rut to another. What really helps our brain is variety, doing things differently. Anybody here besides me ever talk to your patient and think, starting about midway and start thinking, God, is this person or the last person? Yeah, that's automatic pilot. That's automatic pilot. You know, our routines are such that, well, routine is important in life, but when does it go from being a routine to being a rut? One of the problems about a rut, well, think of it like a ski hill. When you're going down a ski hill, you know, the first time you go down, that was a good run. You like that. Second time, hey, that's good. The third, you like it. You kept going down that same path on that ski hill. What has it eventually become? A rut. Very frequently an icy rut. An icy rut that's hard to climb out of. Try to climb out of it, especially when you think there's somebody at the top of that rut kicking you back in. Routine. Got to use it or lose your brain. So we have to look at how we're really training our brain. Now, what that picture is of a lady walking down the stairs. And as you can see, she's very tentative. She's very worried. So her face is looking at her feet. Now, brain fitness research shows is how malleable or how impressionable the brain is. It's called brain plasticity. Yet the brain, what that means is that our brains can continue to grow through our whole life. But they can grow either negatively or positively. And as this lady, she's worried about falling. Well, maybe she fell already. Maybe she has an injury. So she's so worried about falling, she's looking at her feet. Now, she walks down the stairs looking at her feet, but she walks on the slider, is watching her feet, why she's so worried about falling. Now, when her head is pointed down, That is not the natural position of the head when it comes to our balance. Our inner ear balance has to do with our head being up and looking ahead. Well, what happens is when your head's pointed down, this very, very plastic brain will actually rewire itself to the extent that when she puts her head up, she gets dizzy. What she's done is she's negatively programmed her brain. What I just explained to you there is the science behind what you believe you achieve. The brain actually rewires itself. That's why it's really important to really consider, what are you feeding your brain? Are you feeding it negative thoughts of I can't, I won't, it has to be, it's always been, somebody's at the top of my rut kicking me down, it's so icy I can never climb up, I have to do it that way, the patients expect, the receptionist expects, the doctor expects, my children expect. Whose expectations are you living to? And are they positive expectations, or are they expectations that are bringing you down? I have to see, I have to do a prophy on every patient when they're sitting in a hygiene chair. It's the only way dental hygiene is productive. Whew. How are you training your brain? Exercising your brain builds brain fitness. You notice I've done some things where I've repeated, repetition helps, repetition works, repetition works. Some places I've stressed your brain. Hopefully some places along the line I've made you laugh a little bit. The pictures have made your brain go a certain way. That's all by design. That's all exercising your brain. But exercising your brain isn't limited to just how you think. It's also exercising your body. You want to increase your brain fitness? It's physical fitness. It goes back to that picture of that medicine cabinet. What helps build the brain fitness is our diet helps build brain fitness. See, when we're talking about all of these things and all these relationships that I brought up thus far with our patients, it's not just something about their oral health. It's about their health. It's about their brain. They honor us by giving the gift of their life in our hands. And yet sometimes we're so much on automatic pilot that we don't even know what we're saying to them. Maybe it's time to exercise our own brains. Is there a connection? If you noticed on the slide earlier, there's the Alzheimer's disease connection. Now, Alzheimer's and dementia sometimes are thought to be on a continuum, that there's the signs of dementia and then it becomes Alzheimer's. No, that's not right. Alzheimer's is a very different, it's a diagnosis that usually is really only accurately made after the person passes away. Dementia can be created by a lot of different things. When my aunt was 83, my aunt was single, she never married. She really thought that she had osteoporosis that took her from 5'8" down to 4'6". It didn't start till she was 80. Of course, we all know that that's not the case either. That's another, again, another one of those myths that we had about aging in the past about bone health. We know that our bone density is basically is at the greatest in our 20s, and from there it either decreases or it stays the same. But Alzheimer's, with her, she was declining in a lot of different ways. But we thought it was age, we thought it was this and that. We thought her messy house was just the person, somebody that is, grew up in the Depression. In reality, she was a hoarder. Now, she also was showing some signs of breakdown. Her cognitive just didn't seem to be there. And I went with her to her physician, and I asked him, started questioning the medication she was on, and got a lot of not great answers. So we ended up taking her to her gerontologist, who looked at her medications and took her through all kinds of testing. And she was showing what seemed like some signs of dementia, but the reality was that hers was medication-induced. When the medications were adjusted, when the medications were made right. Her signs and dimensions, she was sharp as a tack. Not too physically fit, though. But see, we believed that that was the normal way things happened. You know, as you get older, you get more sick. No, it doesn't have to be that way, particularly with healthy brains. The CDC in 2013 came up with this campaign. If you're not familiar with it, go over the CDC's great materials over there. Same way I talked about the Baltimore longitudinal study on aging. Again, those are through our government, so that these are all brochures and posters that are all at no cost because you already paid for them in your taxes. This is the Healthy Brain Initiative. What we can do to keep our brains healthy. Now, it certainly, again, is for our patients, but it's just as much for us, because that aging of the population is not limited to our patients. It is very common in my courses to have people that have been practicing, 10, 20, 30, 40, 50, and even 60 years. How long are you going to practice? How important is it to have a healthy brain? So what I want to do at this point is open things up for a bit of a question and answer period. I'll come back and we'll do a little bit of a close, but let's talk about some questions now. Dan, do you have some questions there?
I do indeed, Patty. Let's see what we have here. Here's a question. Can a Medicare provider be an advanced practitioner?
That's a great question, too, which I don't have an accurate answer. This is purely a guess on my part. If we can be a provider through Medicaid and through any other insurance carrier, then I don't know why we wouldn't be able to be a Medicare provider. But I can find that answer out more specifically by talking to the co-authors on my book, which are much greater experts on the subject than I am.
Sure thing. Let's see. You inspired someone to start flossing during the presentation. I thought I'd let you know. Okay. So, fortunately, there was no webcam, and they were on mute, so listen anyway. Okay. Let's move on here. You referenced the EDA stats that dentistry growth has been flat. Do you have any thoughts as to why?
On a personal basis, I'm going to look at it from a hygiene point of view, as a hygienist, of course, is that an awful lot of hygiene is said, it's pro exam and brush and floss. I mean, I'm sure there's some hygienists on here tonight that if we went out to a restaurant or to a bar or whatever, and somebody said, and if you said to somebody that you're a hygienist, the first thing they would say is exactly what you just said about flossing. I didn't floss. See, I didn't ask. Yet there has been such a routine that appropriate exam and floss and brushing and flossing is the answer to everything, that it's just oversimplification. Well, we have much savvier consumers than we ever had before. And this whole internet thing, they can get good information. Yeah, they can get bad information too, but they can really get good information. And that's what I was talking about. I was talking about the generations and the demographic. Where we're the flattest, actually, if you look at the research, it's from the age of 20 to 54, we're really flat. Actually, the number of boomers is increasing. Why? Because I think the boomers are getting their stuff done before they retire, and they don't have any insurance anymore. And with the Affordable Care Act, we have some increase we have increases being shown on the children end. But it's that middle adults, the adults, like I said, from 19 to 54. That's a big range. That's a big range of people that are not coming back because they're showing us with their feet, but they don't value it in the same way they valued it before. And are there economic issues with it? Sure, all of that's true too, but I think we need to look deeper than that.
Sure thing. Are there insurance codes for the different levels of prevention you mentioned?
Insurance codes. Well, yes and no. I mean, yes and yes, actually. There's insurance codes for everything. As a matter of fact, absolutely everything we do has a dental insurance code. Well, sort of. What I mean by that is the CDT book is divided into 12 sections, and in every section, There was one exception until last year, but in every section there's a 999 code. In other words, that's for when nothing else fits, you can use a 999. Well, here's what's really interesting. Two things happened last year with CDT is until last year there was not a 999 for preventive. So there was no 1999. There is now a D199 for a non-specific preventive procedure. So things that we didn't necessarily, they don't fit anyplace else, we can use that code. Then there is in the 499 code, the D499, that's in the perio section. That was the non-specific code. Well, what's really interesting is we as a public professionals made a difference. In 2012, it was submitted for gingival irrigation under the 499 code over 500,000 times, to the extent that the carriers influenced the coding committee to create an irrigation code. So we have an irrigation code that we never had before. But when it comes to these different levels of prevention, the codes per se are, again, it's about different thinking. So is there a code for using, say, fluorescent technology like a Diagonus or Spectra? Not per se, but we could use it under the 199 code. Well, is that something that will be paid? Well, that's a different question. When people ask me about codes, codes are one thing. Coverage is something different. Codes, as professionals, we have an obligation to code the most accurately as we can. Coverage is just what somebody bought as a contract. They're not the same. And the routine has been that we don't code something if we think there isn't coverage. That's perilous on all kinds of levels. First of all, we don't know what coverage is unless you got a policy in your hands. You know how to read it, and you know how and you know what was bought. Most clinicians don't have that. The other part, though, the other peril is if we don't code something, there's not a measurability to it. So if we can't measure it, we can't say that it was successful. An example, D1330, the oral hygiene code. How often is that coded? How often is it documented? If they go to one hygienist who says use the Sonicare, somebody else says use this, somebody else says use that, and the patient still has declining health, and then we say they're not compliant. Well, compliant to what if we didn't document it? That's where, are there codes for these different levels of prevention? It's really about different thinking.
Okay. Where can we learn more about dentists opting in or opting out?
There, if you start looking at it, now that I made people aware, Google it, okay? But you can go to the ADA website. You can go to Medicare, but that's perilous unless you really, really have an idea what you're doing. There are people out there, again, my partners Christine and Jan Palmer are a couple of people that are working in that arena and definitely would have answers. Terry Bradley is another one. But you go right to the ADA, American Dental Association website and get information. Dr. Melmacher had articles, actually has 3 out of his 5 articles have appeared in Dental Economics as answering some of these questions. But that's some of the resources. But it's like just being aware of it first and then going up and then you know. But this time thing is what's really going to be a problem. It's only, again, till June 1st, and it all has to be decided, and all the paperwork has to be done by June 1st. But people got to get on that really quickly.
Good advice. Here's one that's close to my heart as a health coach. Obesity is a factor in the oral systemic balance, but what can dental professionals do about it?
Well, one of the things that I've even talked about is, and asked the question, why don't we have scales in our offices? When I go to my physician, what's the first thing I need to do? Well, most people say get on a scale, but that's not right. The first thing I have to do is give them my insurance card. Second
of course.
Second thing I have to do.
So they can justify the 8 minutes they're about to spend with you.
Exactly. Is get on a scale. Now, why do I get on the scale? Well, because they're mean, nasty people. My driver's license says I weigh 125. That's a good number. It isn't accurate, though. Because what we know is, it's about medications. It's about change. It's about, it's part of the diagnostic process. It's a vital sign. Now, do we use medications in dentistry? Are vital signs vital in dentistry? Yeah. So there's one of the things that we can do right away about it. Now, would that be a change? Sure, but it was a change, I know, in my career when I brought the blood pressure cuff into practices. And here's a really simple thing to say when we are making changes. What we now know is, that's all. What we now know. And taking blood pressure. And you don't do it all at once. You just, it's about gradually coming up with a program. But then what is it? I mean, it's the same as having a smoking cessation, tobacco cessation program. You need an actual program, not just, you know, stop eating, you're too fat, or stop smoking, you dirty pigs. Those are really not programs. You need to have an actual program that we can help teach. There is a code for nutritional counseling. This goes back to what I was saying in the part about medical dental necessity. Part of the reason why things don't get covered is because we don't even document the medical dental necessity. What is that? Why we're doing it? So if you have someone with a weight problem, you have a scale, you have done more than just have a scale and now you tell them to eat less, you have an actual program, would that be covered? I don't know, because remember, codes and coverage are different things. But if you document the medical necessity, then you learn about medical cross-coding. Is it possible that it be covered under the medical insurance by care that's done in a dental office? Remember, that's what I said is our opportunity at the beginning of this course. There is our opportunity.
Next question, why would one use art versus just, quote, fixing teeth?
That question comes from a dentist? Because, see, I know, and I don't
didn't identify himself.
No, I'm not saying it in a judgmental way, but I know that art and the whole idea of art, or you know, the pediatric term that we have for it, IRT, is very contrary to the education of most dentists. Because it's not about, why would we leave that? Why would we seal over decay? This doesn't make any sense. But it's again, it's just looking at things differently, and that's from that minimally invasive or minimal intervention point of view of knowing that invasive, because it's going to be invasive dentistry, is not going to restore health. Restoration of health is different than fixing teeth. And that's why we want to do art, because we want to actually protect the person from further breakdown, as well as the biofilm pH issues that are going on in those active sites. It's about stabilization. Stabilization so that they don't get worse while we help them get healthier. Because if we just do the restorations in the traditional way, or the prosthetics in the usual way, how often do we see new breakdowns? The reason is that we haven't stopped the disease. All we've done is repair the damage from the disease.
Very good. What other options do we have for diagnosing perio disease?
Wow, that's a really big question to which there are multiple answers, and this really goes into all of these things that I'm talking about here with looking at vital signs, with looking at other laboratory-type testing, CRP, C-reactive protein. What is their level of the inflammatory factor? That's one of those tests that can give us information. Now, we might not always know where the inflammation is coming from, but if there is a higher level of CRP floating around in the blood, then we know there's some kind of inflammation, and then we need to treat the periodontal disease and see if it gets lower. That's one of many blood tests, as well as saliva-based tests. It's really exciting the work that's going on with saliva. Dr. David Wong and his team of researchers out at UCLA, Department of Salivary Diagnostics, are really looking into this whole thing of a lot of things that have been done with invasive blood tests that we can now test with saliva. There's a new test for the it's called Salamark, and what it is, and it's based on Dr. Wong's work, and that's if you see a lesion in the mouth that you can test it to test this through the saliva if there's certain RNA markers that show that there's active squamous cells. Now, I didn't do as good of a job completely in explaining that, but what I'm talking really about is the idea of different diagnostic tests. Oral DNA, we're familiar with their pathogen testing. There's other companies out there, Interleukin Genomics, that's another company that has some other types of tests. But the thing is that we need to look at that to determine what the test should be. Remember that continuum I showed that on the medical side, they gather the risk, and then they decide the diagnostics to make the diagnosis before they make the treatment. That's the part that we got to get in our head, because we're not going to come up with the right diagnostics until we figure this whole thing out that way.
And those who are interested in learning more about David Wong, he actually presented at AOSH's scientific session last year in St. Louis, and you can go to the AOSH website and purchase a DVD of his presentation, which I found quite fascinating, and I think you will too. Let's see. Well, you said restorative dentistry does not restore health. I think we covered that pretty adequately. And perhaps this too, but this bears perhaps a little bit of attention. Is doing nothing about Medicare really such a big deal? They don't pay for dental anyway.
Doing nothing is the choice an awful lot of times people make. They decide by not deciding. Well, the peril in doing nothing is that first of all, you're going to be locked out from changing your mind for 2 years. Second of all, decisions are already being made for you that you don't know anything about. It's very perilous to do nothing, because to me this is really about most everything in life. Deciding not to decide is a decision.
It's a decision.
It's a decision. It really is. And sometimes it's like, let's play ostrich. So many offices, so many practitioners, like when it comes to electronic health records, and when I talk about diagnostic coding, oh my gosh, they really want to play ostrich. But ostrich doesn't really do us any good. It can hurt us in the long run, especially when things are in their formative stages. Like, Danny, you brought up a couple times AOSH. You and I, as founding members of that organization, I feel a great deal of pride and love, and because I had something to do, and you had something to do with the formation of something. I contributed to how something would be. See, that's where I think deciding makes a difference. I decided I wanted to make a difference. And that's really what life is all about to me.
Amen to that. And let's have our final question here, which is, you covered some of these. Do you have a suggestion for what kinds of diagnostic tests be included in a patient's oral assessment or exam? Maybe some others. But you've already mentioned quite a few.
I mentioned quite a few. I mentioned quite a few of the options, but I think what is really important is just to go back to the basic, what is included in an oral evaluation. Now, the term oral evaluation isn't an oral exam from a coding perspective. Now, I keep bringing up the coding thing because it's really important that we understand that coding can be considered part of our standards of care. Why is that? Because HIPAA designated back in 2000, CDT is a standard code set for dentistry. I think an attorney could argue that with the language in the federal rules of the standard code set that is part of our standard of care. One of the things about oral evaluations is they're not the same as oral exams. We've used those terms interchangeably, but by the coding perspective, the oral evaluation includes a diagnosis and a treatment plan. That means if you need to document it, because if you didn't document it, you didn't do it. But all the different pieces and parts that are and listed, it's a code that's really long. How are we even doing that? A full periodontal chart, a full chart of this, a full chart of that. What are all those pieces? Because for me to talk about the adjuncts, let's talk about the basics. With a periodontal chart, is it just pockets? No, it's way more than that. That's where another thing that influences practice is the standards for clinical dental hygiene practice. That was accepted by the ADHA in 2008, and every hygienist needs to know what they say because that's the standard we would be held to. And it lists very specifically the pieces and parts of what is part of an oral evaluation exam. And then after we have those basics, from there is where we decide and determine what are the next best diagnostics. It's not that we're skipping all those other things. Those first things determine, as well as the health history and a lot of other risk assessments, that determine which diagnostics are appropriate.
All right. think we have a few concluding remarks that we want to save some time for, so I think that's all we have for questions.
Well, Danny, you know what? We could end up like this. And although with our weather in Chicago at this point, I think that looks actually not too bad. But and not on a bench like that. We could end up like that. Yeah, strong. This guy's 83. Look at that. He's doing push-ups. The thing is we have an opportunity. We have an opportunity to really make a difference in the dental office and helping more people be like this. We really do. We talked about the 5 action steps. Change the language, evaluate inflammation, change the care we provide based on systemic, recognize and do something about abuse, and find ways to keep our brains fit. Those are 5 action steps. You can start any one of those, possibly all of those, tomorrow. Tomorrow. Aseptico's here to help. By the way, it's Aseptico's 40th anniversary just this year. They've been around 40 years, and I found this picture on the internet of them on Halloween. It was just too funny for me not to put up there. What a great company.
Oh, I thought it was Casual Friday.
Well, I have to ask Chris Berry about that.
Yeah, well, you don't know him like I do.
I'm thinking any kind of company that is this much fun, I want to get to know. Many things
let me put in a brief plug for them, too, because they're very supportive of our Climb for a Cause and Smile Tree Foundation. So, and they've also donated and offered their equipment discounts at deep discounts for people that participate in overseas or domestic volunteer work. So, yeah, they're great folks.
They really are. They really are. A lot of things you can do to look, you can feel younger, but most experts agree it's to be born later. Yeah, we can do something better than that. We don't want to regret growing when we were older because, actually I just heard today, one of my very closest friends, her brother passed away at the age of 47 of bile duct cancer. Growing old is a privilege that's denied to a lot of people. We've come a long way as a profession. We're an amazing profession. That's a picture of Pearl Harbor, December 7th, 1941. When the military leaders had to decide what it meant to be devilly fit to go to war, they said, hey, you know what, the same thing that we had for World War I, it's good enough. And what that is that we had to have 12 functional teeth. But here's the real power of the story. By the end of 1943, they had to drop that parameter because they couldn't find enough young men with 12 functional teeth. See, we've helped this baby boomer generation to keep their teeth for a lifetime. We've done amazing work, but it's not time to step back. We can extend health span to go along with lifespan by bridging the neurosystemic gap. And there's certainly a benefit to the patient. There's a great benefit to the practice, but it's also a benefit to us. Us as individual practitioners. Challenging ourselves beyond our routine increases our brain fitness. I want to thank every single one of you here listening. I want to thank Danny from AIM as well as my friends at Aseptico. Please feel free to contact me for anything with insurance or anything we talked about tonight. If you do want references, I'm there for you. I have your back. Thank you.
Thank you, Patti, for that fantastic presentation. You never failed to deliver. And I know that we're all also very excited about the release of the latest book in your dental codology series. We'll watch for that. And I wish you the best. Another April Fool's unveiling, as it has been for the prior 2 years, right?
Absolutely. Well, the Medicare book comes out March 1st, and then the third book in the dental codology series will be out April 1st, April Fool's Day. Yep.
Okay. Now I want to remind everyone to mark their calendars for Thursday, March 26th at 7 p.m. Central Time when Practice Perfection welcomes Angie Stone, who will deliver No One Should Die from Dirty Teeth, Viable Solutions to Our Oral Health Epidemic. And as Patti has already shared, the release of Angie's book, Dying from Dirty Teeth, will coincide with her presentation, and we are both honored and excited to be a part of that launch as well. In the meantime, this is Danny Bobrow thanking you for your commitment to practice perfection. Goodbye, everybody.